I'm Leonard Gomella from the Department of Urology at Thomas Jefferson University in Philadelphia, and I'd like to thank the organizers, John and Peter and everyone, and Grand Rounds in Urology for being here at this meeting. This is a very historic meeting. As you know, this is the 35th year that this International Prostate Cancer Update has taken place. So very happy to be here, certainly. I'm happier to be here because I'm glad I'm not at work today, because I think half my people didn't show up for work back in Philadelphia. That's the usual. That was the last time we had a Super Bowl win. So my charge is to talk about combining secondary biomarkers and MRI, and I think this is a really interesting area because it shows how precision medicine is moving forward. I have to show you my esteemed leaders made a good investment earlier this year by sponsoring the Eagles. So you can see Jefferson and Eagles stuff all over the place, and I'm sure it'll be even more visible once we get back to Philadelphia. So challenges in diagnosis of prostate cancer. We would like to reduce the diagnosis of clinically insignificant cancer. We would like to identify men who have risk of clinically important prostate cancer who may benefit from earlier diagnosis. And lastly, avoid the number of unnecessary biopsies and complications and costs. Although I have to put a little underline there with transperineal biopsies that have kind of taken over. We see very, very, very few complications, but nonetheless, complications are still possible. So what we're going to talk about is multiparametric MRI and how biomarkers put together may address these issues independently or when used together. So I wanted to show you this historic image that goes back to 1982. This was the first image of a prostate MRI, which was a 0.04 Tesla magnet. And of course, we all know how beautiful the images are today in 2025. Also, first serum biomarker, PAP, an oldie but goodie, but as everyone knows, that's come back in various forms and incantations, including some immunotherapy. But again, it was the first serum biomarker that we had. So what do we have today? A huge list of biomarkers. There are so many biomarkers or guides to perform prostate biopsy. It's really hard to keep up with all of them. Online calculators, molecular blood tests, PSA-related blood tests, and of course, one of the common things that we have are the ability to use simple urine-based tests, and of course, imaging is one of the common biomarker guides to perform prostate biopsy. When you look at a recent review of a lot of the different biomarkers, sensitivity, specificity, nobody's batting 100, but it doesn't mean that they're not good. They're mostly better in a lot of the categories than PSA, whether it's a urine score or a serum score. Again, we can do better, and all the worker and a lot of the people on this program are working aggressively in the area to improve the accuracy of our biomarkers. So they're good. Better than PSA, but still not perfect. So what do we have for biomarkers? What are the benefits and limitations? They're generally non-invasive. They can support, most of them, an early diagnosis. Some may indicate aggressive versus non-aggressive cancer. However, what's the limitations? One of the big problems I think we all run into is the insurance coverage. Though we're not going to take care of that. The companies are pretty good, but there is sort of a hassle factor that you have to go through to get some of these tests covered. They may not be available all around the United States. We really don't have a lot of comparative studies comparing one biomarker with the other. And of course, the last thing is we really have limited randomized clinical trials in this area. So let's talk a little bit about MRI right now. Certainly multiparametric MRI is the darling of our world, which has really taken over the last 10 years. We do have large clinical trials. For example, the PROMIS trial looked at clinically significant cancer, generally, grade group 2 or higher. And what that study really found was that multiparametric MRI was a sensitive test. It allows you to avoid biopsy in some men when you did not see a lesion. But here's when you drill down a little bit further. If you look at the study, about 18 more cases of clinically significant cancer were identified based on the trust biopsy component. So this is where a biomarker opportunity may exist to capture that last little group of men who may have a negative MRI. Precision trial, same concept, MRI targeted or standard biopsy for prostate cancer diagnosis. Again, if you look at the high PI-RADS 4 and 5 scores, pretty good. Even when you get down to PI-RADS 3, however, you can see that there were a number of men who were not diagnosed with clinically significant prostate cancer. Again, another opportunity to bring in a biomarker. So what about the multiparametric MRI benefits? There's no question MRI can help localize the lesion in many men. Another interesting thing, and I recently thought about this, really the PSA density is kind of a surrogate biomarker. If you have a very low PSA density on an MRI, you may consider it as a surrogate biomarker because you have a much reduced risk of having prostate cancer and clinically significant prostate cancer. And of course, multiparametric MRI is embedded now in all of our guidelines. However, again, if you do a deeper dive in a lot of these things, the NCCN guidelines actually use the word caution. When you look at a negative MRI and you're worried about a patient, you should view that MRI with caution. Also, the AUA guidelines call for trust biopsy. If you've got a PI-RADS less than 3, and they endorse targeted biopsy for PI-RADS 3 to 5, but if you have a less than a 3, the AUA guidelines also suggest you should do a trust biopsy. Again, another opportunity to bring in biomarkers. So multiparametric MRI is great, but it has some limitations. And again, the more studies you read, the different authors highlight the benefits and the downsides of multiparametric MRI. But the MRI studies really are all over the place when you have very, very broad differentiations in sensitivity and specificity. You can have false positives from BPH, inflammation, fibrosis, and high-grade PIN, and there is a lot of variables. Who's reading the MRI? In the Philadelphia area, we don't trust a lot of the MRIs done outside of the academic centers because they're very cursory, and we kind of don't trust them. But again, if you look at the negative predictive value, depending 7 to 10%, some series as high as 35% for high-grade cancer not seen on MRI. One interesting study that I found was if you had a negative MRI and you followed the patients for 2.4 years and they were rebiopsied, it turned out about a quarter of them did in fact have high-grade prostate cancer. So again, an opportunity to take a good MRI and maybe make the diagnostic algorithm better with a biomarker. So the reasons we miss clinically significant cancer on targeted MRI, there's no question that the targeted biopsy is superior to detection of higher grade cancer over transrectal biopsy. But again, the poor targeting of MRI or invisible lesions on MRI is where we're worried about. If we see a lesion, we're pretty good. If we don't see a lesion, that's where we run into problems. So again, this might suggest a complementary role using biomarkers along with MRI. A recent Cochrane review, and maybe many of you are familiar with the Cochrane service. It's an independent review group that takes a topic and does a deep dive on all the different papers that are out there. Their study showed that the negative predictive value for a multiparametric MRI was 91%, but again, up to 10% of men with clinically significant prostate cancer were missed on the MRI. Again, depending on whose paper you read, this is an amalgamation of many different studies. Again, another biomarker opportunity to pick up those 10% of men. So where are we with the parametric MRI in 2025? We all agree TRUST is a poor test for clinically significant prostate cancer. And it's generally superior, but not perfect to identifying grade group 2 or greater cancers. It identifies a lot of men who might safely avoid a biopsy, but as I just showed you, other papers show if they have a negative MRI and you don't biopsy them, about a quarter of them 2 to 3 years later, if you have a suspicion of prostate cancer, may have cancer. All of the guidelines now, everyone has multiparametric MRI in the algorithm in the management of prostate cancer. But again, as we've noted in multiple studies, there's still a miss of some cases of clinically significant prostate cancer. And not to mention PSMA scan, but this is kind of coming in as an overlay now of this whole topic, but there's really not a lot of literature out there, but something we have to keep an eye on. So NCCN talks both about MRI and biomarkers independently in the early detection algorithm. And again, the NCCN group has their favorites when it comes to the biomarkers that are listed there. But at the end of this discussion, this intro, biomarkers and multiparametric MRI may actually prove to be synergistic in the future. We've seen studies that demonstrated correlation between increasing PIRAD scores and biomarker scores, suggesting that the performance for high-grade cancer detection does improve when the multiparametric MRI and biomarkers are combined. The MIPS study was significantly higher in patients with grade group 2 within each PIRADS, indicating that they may provide additive or complementary information. So what studies are actually been out there? There was a Select MDX study that looked at the urinary levels of Select MDX, and basically at the end of the analysis, for all cases of multiparametric MRI, PIRADS 4 and 5, didn't matter what the Select showed, you should do a biopsy. However, at the low PIRADS level, if they had a positive Select MDX, it suggests that the patient should be biopsied because they might have clinically significant prostate cancer. There was actually a 4K score out there with multiparametric MRI. The only limitation of this study was that not all men in the study actually underwent a biopsy. But the bottom line, as you can see, is adding a 4K score to multiparametric MRI did improve the predictive performance for finding clinically significant prostate cancer. There's actually a very large UK study going on, which will give us further information about this, known as the Reimagine trial. And they're doing a large cohort in men with suspicion of prostate cancer who then get referred. Now, what's the suspicion of prostate cancer? Family history or an elevated PSA. But what's interesting in some of the early results of this study, where all players came in, everyone got an MRI, and if they had a lesion, they were biopsied. They found a significant number of men who had family history and a normal PSA did in fact have clinically significant cancer. So again, another biomarker opportunity. This study is ongoing. It's probably going to take several years, but it's probably one of the most comprehensive collections prospectively of clinical specimens that are going to allow a major amount of work done. And again, PSA less than 3 is also included if they have a family history. So economically, this issue of urine-based versus MRI imaging reflex testing has been looked at from a financial standpoint, and the bottom line is this paper from 2021 suggested that using the biomarkers as a reflex test could be more cost-effective than using the multiparametric MRI in someone who has a suspicion of prostate cancer. So each has its advantages and each has its disadvantages. The biomarkers are non-invasive, blood test or urine test. They're very quick. They can be objectively analyzed based on the parameters of the analytes. Newer biomarkers are better, and they can actually identify clinically significant prostate cancer instead of just saying prostate cancer, yes or no. But what's the downside of the biomarkers? Certainly they can't determine where the lesion is within the prostate. And as we alluded to earlier, there is some availability depending on where you are in the United States. And again, there are cost issues, and often insurance companies may or may not cover them. But I will have to say that most of the time we're very lucky that the commercial companies will work with patients and limit their out-of-pocket costs if we really want to get a biomarker, at least in our Philadelphia area. What about multiparametric MRI? It's non-invasive. It visualizes the position of the lesions within the prostate if they're there. And these days, covered by most health insurances, we rarely get denials for MRI. It's now denials for PSMA scans. But there are some contraindications. Some patients just can't do the MRI. Some patients have hip prosthesis that interferes. There can be other contraindications. It is a costly test. You know, when you go over to England, you know, apparently you can get an MRI for about $300 US, which is not the case here in the United States. That's why I think that really the MRI has been taken over, certainly in the UK for this area. And the other thing, again, this is a subtlety. I think it's getting better. The imaging protocols are all different. There's expertise among radiologists. You know, you have somebody who's doing a neurology exam at 2 o'clock, a prostate at 3 o'clock, breast imaging at 4 o'clock. I think to stick with the individuals who have expertise in large settings really helps with the interreader variability, although I think as the years go on, it's getting better and better. So bottom line is I think that biomarkers and multiparametric MRI both provide different information, and at some point we may see more and more indications that the two may actually be complementary tests in the future. And this was our Zoom background that we were asked to use the last few months. This is not new. Everything in Philadelphia was apparently green last night, but I think my esteemed leaders made a good investment in the Eagles, and we'll be capitalizing that for months and months. So again, thank you all for your attention.